Good morning, welcome. We're just waiting for a few more people as they join, and then we'll start. Great. It's just on 8:30. Good morning, welcome. I'm Christine Hancock from C3 Collaborating for Health, and delighted to welcome you all, and especially to welcome Dr. Stella Lartey to this morning's international seminar. This morning in the UK, in a very damp, slightly grey London. And for people joining from outside the UK, we've come to the end of an amazingly unusual, hot, dry, sunny, certainly in the south of England, and really welcoming some rain to our dry, parched land. C3 Collaborating for Health is a global public health charity. We've been around for about 12 years, and we're concerned with the prevention of chronic disease, what internationally are known as NCDs, non-communicable diseases, and in particular, the risk factors from the way we live that really drive the chronic illnesses of cardiovascular, diabetes, cancer, and they are, as I'm sure many people know, smoking, what we eat and drink, and our lack of physical activity. And C3 works in a number of ways. We work across sectors, across organizations to bring together as much as possible diverse people who together can make a difference. But one of our big areas of work over recent years has been that of community engagement. And in particular, we have a strategy we call CHESS, Community Health Engagement Survey Solutions, which works in low-income disadvantaged areas to engage local people in really interrogating their environment and seeing how where they live is having such an impact on their health. And currently, one of our big programs is an EU project in southern England and northern France, areas of high unemployment and high levels of obesity. And we have been able, through a 3-year grant, to employ local community person in each of those areas to really work at implementing the ideas that local people have generated about how to make it easier to live a healthy life. And therefore, today's seminar is especially relevant from our point of view, and hopefully for many of you in the audience today. So C3's seminars are aimed at bringing people from other countries with experience of the work they have done, which hopefully will stimulate the ideas and possible solutions for people in other countries. Originally, 12 years ago, they were designed as breakfast seminars based in London when people came through London for a variety of reasons and would give a seminar. And we provided lovely breakfasts. Obviously, from the beginning of or middle of 2020, they've had to move online. And they've stayed online because that's made it possible for us to reach a much wider audience and possible to have speakers who don't have to be in London. So we're really delighted today. Dr. Lartey is slightly a cheat on our normal seminar, and a delightful cheat, we're really pleased, in that she's actually currently working in the UK, but she's bringing us today lessons from her home country of Ghana, but others as well, where she has seen community health workers in action. So, Dr. Lartey, we're delighted that you're here. Looking forward to hearing you. Hopefully everybody except you will be on mute, but there will be plenty of opportunity to have discussion and questions at the end of your presentation. Over to you, Stella.
Thank you so much, Christine. So I'll go ahead and share my slides so that we can begin the session. Just a moment. Great. Just checking. Please, are you able to see my slides?
We can. That's perfect.
Great. Thank you so much. Right. So just a quick disclosure. I'll say thank you again, everyone. Thank you for making the time to be here. I have these disclosures. I acknowledge the nations, the communities, the people who participated in studies used in this presentation, and with whom I have worked and with whom I have volunteered. Generally, if I'm not working or with family and friends, I would most often be in the community volunteering for a project. In Ghana, I would mostly volunteer for the screening for non-communicable disease risks and for elderly social and mental health. In Japan, I was volunteering for elderly social care and child's language exchange programs. In Australia, I would mostly be volunteering for adolescent education. In Canada, for the Scouts. In the US, for elderly social life. And I will begin volunteering very soon in Norwich. Thanks to all the organizations I've worked with and volunteered with. Whilst I have worked with these organizations, the Ghana government on a number of projects, and now with the University of East Anglia, the views shared in this presentation are mine and hence my responsibility. Thank you so much. Let's dive straight into the presentation. And so today I discuss, and I would love that you ask questions, you bring up your ideas and share your thoughts on these lessons I'll share with you. I was just discussing with Christine that I tried as much not to only focus on Ghana, but also to share what other countries are doing, both in low and middle income countries and high income countries, so that we're able to learn what others are doing and to see whether this could be applicable to the UK, to communities in the UK. So that is basically the outline. Right, I go straight into Ghana. So Ghana is quite a small country, and we have a number of regions, but bordered by mostly French-speaking countries, while we are English-speaking countries. So if you move to east, west, and the north, you have to be able to learn to speak a little bit of French. And down south, we enter into the ocean. I have focused a little bit on Navrongo because this is a point where we could demonstrate that community health work in Ghana have really supported us in achieving a number of goals, including those of the MDGs, universal access to healthcare, among other things. So historically in Ghana, the community health workers existed in the form of village health workers before the 1980s, but their activities were curtailed with the introduction of the primary healthcare strategy. Just a pause here. If you want to ask any questions and give me prompts, please feel free to step in to do that. And Jake, I'll be happy if you time me well. Thank you very much. So I'll quickly continue. So we introduced the primary healthcare strategy. In this strategy, the focus and the main workforce was to train the community health nurses. And so we trained and deployed them into the community. So basically, we cleared the community health workers from working within the health sector, or the activities were mostly not palpable any longer. But now we focused on the community health nurse working within the community. Oh, then when we deployed the nurses into the community, we had a hitch. So there was disaster. We hit the iceberg because we only saw just a tiny part of how the community operates, how the community is organized. And so upfront, key things or key challenges that came up were residents and workplaces for the nurses. They are not from the community, they are just deployed into the community. Then distances and transportation into the community. Community connectedness with initiatives. If they are not connected, is really hard. It's really hard to even get them to participate in something, to get their feedback. They think that, oh, they brought their program, let them run their program. Then mechanisms to foster community contributions were also not so clear, because you bring totally a vista into the community. They know nothing about the community. They have to learn the community, how to enter into the community. Community entry is very key if you want to work in any community. These community health workers, though trained, but trained mainly on how to deploy or provide services, formal health services, and not really akin to how they manage themselves or they manage communities in the course of delivering services. So mechanisms to foster community contributions were also challenged. It was challenged. Then sustainability of operations and initiatives. This Vista, who is a community health nurse, comes and do whatever services or conduct whatever services they have to conduct. They succeed, they are happy, they leave, and they come back and the problem crops up again. And the initiatives, the successes are not really recorded, neither are they sustained in the community, because the community returns to their old ways of doing things. So we had few years to be able to achieve the Millennium Development Goals. And if you look historically at services, health services in Ghana, we've had major challenges saddled by infectious diseases, parasitic diseases like malaria. We are currently also experiencing the upsurge of non-communicable diseases such as diabetes, hypertension, among others. We had few years to be able to achieve the Millennium Development Goals, but we didn't have, well, we had a strategy to use the primary healthcare strategy, but that was not really working. And so based on policy debates, operational debates and deliberations, the Navrongo Health Research Center came up with this landmark trial in 1994. It was led by Philip and Professor Binka. So Professor Binka I've directly worked with, and he's currently with the whole university. He works in a number of capacities in Ghana. So they developed this trial. The trial had about, the trials had two main arms, the comparative arm and the experimental arm. Yet the experimental arm had three experimental cells within that. Let's discuss a little bit about that and the achievement and the birth of the CHIPS program in Ghana. So in 1994, when this trial took off, the comparison arm was where nothing was done. The first experimental cell was called the Zurugelu arm. That is, Zurugelu is, the meaning is just friendship. friendship or togetherness, people working together. And so, as the name depicts itself, communities led to reduce child under 5 mortality, increase the uptake of family planning, reduce maternal mortality, among other things. And then the second cell was where we used and deployed mainly the community health nurses. Then the third cell sought to combine the community health worker with the community health nurse in the community. And so we brought together the community health nurse, the community health nurse and the community health worker in one cell to work and see how we can achieve the MDGs. And as you can see in this graph, if you pick the comparison arm, which is these squares up here, you find out that we're not going to achieve the MDGs. Let me cut that short. If you use the first experimental arm, we had a bit of challenge. We would achieve success at some points. You see that in circles, and then some points we were high in our challenges again. It was just swinging up and down. And then we moved into the third experimental cell, where we combine community health workers with the community health nurses. And that is the excess you see in this graph. This led us to achieve quite a lot in a short time. We reduced under 5 mortality, and it also helped in the uptake of family planning methods, the understanding of formal healthcare and other alternative formal healthcare that could deviate the community, or that could propel the community from the surge of diseases and deaths. And so, as you can see in this graph, what we could achieve with the experimental arm was very significant. This line shows, the dark line with the rectangles show the what we needed to achieve, what we needed to do, where the MDG was targeted to be able to get to. The communities in which we did nothing is shown in green, and the communities in which we could combine community health workers with community health nurses is what you see in the black line. And you can see that we achieved the MDG, we crossed and we're achieving more, even below that of the target. Probably safe to say that above and beyond what the MDGs were set out, our targets were set, right? So this led to the birth of the CHIPS. The CHIPS is just community health-based planning and services. Note that in 1994, with the success through the trial, this was done in a small community. The community is the Katsina Nankana district. We had this done in communities within the Katsina Nankana district in Navrongo, around Navrongo. And by 1999, we rolled out gradually this process of combining community health workers with community health nurses to be able to achieve our aims. Of course, in 2005, we saw challenges and we tried to surmount these challenges. And in between 2014 and 17, when I was the national coordinator, I would want to acknowledge the teams that I worked with. I didn't work alone. I worked with teams. I worked with policymakers from various sectors other than just the health sector. The main implementing arm I worked with is the Ghana Health Services. So with these teams together and architects, we reviewed the CHIPS policy and relaunched the policy as well as launching 64 chip compounds in deprived areas across Ghana. This project that we commissioned and reviewed, within which we commissioned these compounds and reviewed the chip policy, was supported by budgets within the Ghana government, JICA, and DFID. You would find more, or you can listen to more of this in the slide. I think the slides will be shared. You can listen more to what the YouTube that I've implanted in the slide. So major achievements from using the community health workers in combination with the nurses, and sometimes only the community health workers in communities, are as follows. I cannot list all of them here, but these are major things that we could achieve with the community health workers, working with the health systems that were already in place. So we could empower vulnerable groups, and therefore we could reduce inequities and inequalities in communities. We were able to connect well with the communities. We connected the communities to the health systems, and because at a point it's like the communities were trying to run their own lives. The health systems didn't really understand what community needed, but with the community health worker as the major bridge to the community, between the community and the health systems, we're able to achieve a lot. Then now communities began to own projects and initiatives, and succeeded in sustaining benefits and further prolonging these benefits. We're able to achieve the community, the guinea worm eradication. I'll show you one of the planning stage documents. It's not the final document. I intentionally did not show the final document, but the processes for you to know that working with the community health worker also takes a lot of planning. And this was done in the guinea worm eradication situation, the expanded program for immunization, obviously widely known as the EPI. We're able to reduce our maternal and under 5 morbidity and mortality. HIV management was drastically done, and we're able to improve our numbers, reducing infections and further progress in reducing the rate at which people progressed into AIDS. Then we could achieve a lot in malaria treatment. Obviously, we won't say that that is the direct impact, but indirectly, using the community health workers, we're able to increase life expectancy. We saved a lot of money within the health sector, and then we preserved the efforts and made it more efficient. We preserved the efforts of health workers and made their time use more efficient and effective. Then indirectly, overall, we'll say that we increase productivity with the introduction of community health workers in Ghana. In other low and middle income countries, examples are listed here. The disclosure is that I have not worked in all these countries, but I have supported work in Uganda and Kenya and in Tanzania around community health work with colleagues in these areas. So in many low and middle income countries, community health workers working with the health sector or working with the health system have proven to be very useful, very efficient, and have helped in significant achievement or significant impact in these communities and in these nations. But do we say, or should we limit this workforce only within the low and middle income countries? Have they not done anything in high income countries too? Well, there are evidence out there for all of us to examine, and I'll cite few of these here. So, integrating community health work into the Australian system led to um, removal or removing language barriers. Because note, as a community volunteer and also as a health worker, I have had to learn a number of languages. And so I could speak about 5 to 7 languages in Ghana because I have to go into communities, try to communicate with them. But with the community health worker who is based in the community, I could easily communicate with the community. When I'm talking about childcare, is exactly childcare that is communicated to them, not something else. So language barrier has been a major challenge. And in Australia, they've seen that introducing the community health worker and merging their work with the health system reduced language barriers. Then it increased cultural appropriateness of services. I'll talk more about this in a moment. Then it also served as a bridge, a trust bridge between the communities and the health systems. Let me pick a little bit on the cultural appropriateness of services. For example, in Ghana, there was a time I had to work as a community health worker, not necessarily a community health nurse, but a community health worker in a number of communities in the Kwabre district in Ashanti region. And we're supposed to discuss issues of family planning and child birth control, as it's commonly known. And if you enter into the community inappropriately, one thing you're going to get is they will look on. Sometimes they will turn up to outreaches, but they will not participate. They are just there to listen to you because they think that you don't understand what their culture stipulates or how they live. You don't have any understanding of what they have to face each day, walking distances to fetch water, drinking mud water. I mean, how community communicates in every community has some level of organization of communication channels. You need to understand this so that whatever project you are designing with the community, it would be appropriate for them. So I could not just walk into specific communities and start talking about condom use. It is forbidden. I could not just walk into communities and pull women to speak with. I need to ask for permission from their husbands or their partners. I needed to visit chiefs and palaces to be able to ask for permission to speak with the people in the community. So community or cultural appropriateness of services was very important to define in every community I had to work in. And this is a reality not only in Ghana, but also in Australia and in other places. In Canada, though community health work is not really recognized or regulated, literature has shown that it's often demonstrated a reduction in health inequities in marginalized populations, and it has reduced the cost of medical services. For example, I would say in Ghana, there are some services that the community health worker, if trained properly, can help administer without you bringing in a medical officer or a GP to that level. You need to pay for them, you need to look after their welfare and other things. But with the community health worker in the community, understanding the community, they liaise with the GPs, with the physician assistants, with the community health nurses to be able to implement the same services at much lower cost within the community. And we saw this in Ghana, and Canada is also seeing similar. In the United States, if you use the healthcare workforce with working with the community health workers, have improved patients' experience in healthcare. It's improved population health. There again, we are seeing reduction in cost of care and improving the experiences of both clinicians and staff. Could we think about some of these achievements in other high-income countries? In the UK, I'll leave that as for discussions in the next segment. But the good thing is, could we think about using the community health workers to help us in our aging populations, in our social health care? These are all questions that I would like us to look at as we discuss this session in the discussion session in the seminar. So I'll quickly go through the lessons learned. Operationally, when I say operationally, let me just throw a little bit more light on this. So we have, in Ghana, we have the policy arm and the operation arm. That is the implementing arm. The policy arm is led by the Ministry of Health, and they have to deal with policies, policy budgeting, liaising with policymakers, the parliament, and the presidency, among other sectors. Then the operational arm, that is mainly about implementation, is led by the Ghana Health Services. I would acknowledge that there is the Christian health services, the Muslim health services, and other health services, being the private sector health services also in Ghana. But operationalization and implementation is mostly led by the Ghana Health Services. And so if you see me dividing the lessons into operations and policy, this is the background to it. I'll mention a few. So operationally, we had to develop mechanisms to organize and streamline resources for our community health work programs, because else you tend to misuse resources. You deploy community health worker and community health nurse into a community, or just a community health worker, and you are not monitoring what resources they need. It can lead to wastage. But if you have a very good mechanism to organize, streamline, and evaluate the resources that are moving into the community or being circulated in the community, then you can save a lot of costs. So operationally, there was the need to define mechanisms to organize and streamline resources. Then we had to define and prioritize robust communication messages and channels in our outreaches and in our services. So this has been very key, and I guess most of us will see that in the communications and on social media about COVID-19, the infection itself, the vaccine, and vaccine acceptance. We did some work in Japan on vaccine acceptance. You can find that online. Communication is very key. What is your community health worker telling your community, particularly when you do not understand their language? Even when you understand their language, are they communicating the appropriate messages? Are you going through the correct channels? As I've indicated earlier, communities have organized channels of communication. So sometimes you have to begin with the community leader, you have to begin with the chief or the queen mother or the key community leader, not even the community health worker. But this seeing that you are working with the community health worker makes the channel much more open to receive and accept whatever messages you have. You need to recognize these channels and use them appropriately. And that is what we did in Ghana. And then you have to have explicit operation procedures. I picked and used some of these words, and I've provided the references because these are things we did. These are documented for use. You need to have explicit operation or operating procedures. We don't just enter into the community because we have a service for the community. We have to have a service with the community, developed with the community, and providing very robust options that the community will understand and use appropriately. For example, we had to implement nutritional programs using our community health workers and our community health nurses in specific areas in Ghana. Note that some of these areas, there was the traditional notion that if a child eats eggs, they can become outcasts or thieves in the community. This is quite traditional, and it was well accepted in this community. We needed to have explicit operational procedures and clear messages, acceptable messages as to why it's necessary for the child to take egg. That is not going to destroy the child, that the pregnant woman can have time at the hospital with the community health nurse, supported by the partner. The partner has to be involved. A number of things have to, we had to actually be explicit about it in our operations so that the community can accept our work. But we could not do this when we were seen as visitors in the community. We could do this with our community health workers working hand in hand with us. At the policy level, so just a quick background that for 15 years, I worked from the community level, volunteering and working as a community health worker, through to the level of policy making at the national health, headquarters of the Ministry of Health, where I became the national coordinator for the CHIPS policy. I had to learn also at that level. At that level, I had to learn how to work with other policymakers, other sectors that we would need to deploy programs in our communities. So I had to work with teams to mobilize policy support, political support. You realize that in 2016, the CHIPS policy was promoted and it became one of the key message or elements for the government of the day in their campaign for extra votes. I wouldn't go there because that's not my purview. I operated mostly as a technical person. And so policy mobilization is just very important. Let policymakers buy in. Let the politicians understand the essence of what you're doing with community health workforce and their contribution. Let the evidence be really robust, and you can get validation for policy support in this. Then we have to develop sustainability plan. I guess this is still ongoing. And please note that I worked on this project between 2014 and early 2017. And so we were developing sustainability plan. Then funding has to be clear. Who will fund this? Who can you work with? How can you sustain funding to support community health workers or community health workers programs in your community? This has to be clearly defined, or there should be a plan to support or fund such projects. Then there should be a plan to integrate community health workforce into the health and social service systems, because they also need that incentives to be able to continue working. And as we often have to see, we don't have to really start community health work programs as big and large programs. It has to start small, and gradually, through lessons learned, we scale that up. But we have to clearly define whether we want to scale this or not. And we have to have plans for this. So generally, I would say that the efficiency and effectiveness of community health workers program have to be planned thoroughly. That is what I saw. This is a lesson I had to learn. Start small and progressively scale that up. It should be well implemented, well monitored, and evaluation. And if you read more about some of these projects in Ghana, we have a monitoring and evaluation plan that is in place to be able to help monitor both failures and successes. I should say that we haven't been all that successful. We haven't been all successful. That's what I want to say. We have been very successful, but there were times that we failed, and we had to look at what caused the failure and fix that with the community. Then we have to use feedback appropriately. So if the community says that you cannot discuss condoms publicly, that is a very good feedback for you. If you are implementing community health work program to facilitate the uptake of birth controls or family planning in a community, please take feedback. Use the feedback appropriately, not against the community. Please, there are times that for us in the health systems would like to tell the community that this is what you're doing, this is so wrong, follow our ways. No, that doesn't often work. It actually backfires most of the time. You need to take the feedback, work appropriately with the feedback. And then this is just one of the project design metrics used in the process of planning. Currently, most people will use the logic model. The project design metrics is quite detailed with narrative summaries, assumptions clearly stated for the community, activities, inputs and outcomes, among others, means to use to verify success. All these things are in this table. And these are some tables we had to develop in the planning stages of implementing community health worker programs in Ghana. So these are suggestions for consideration. When you want to plan community health work programs, we need to think about whether it's going to be cost effective and sustainable, ways to fund or funding models, what will be used to enhance and incentivize the community health workers, and whether they would require, the community health workers would require professional qualification in the long term. And are there any formats for recognition of community health workforces in the areas we want to work in? Generally, I would say that interventions and programs that have recognized, worked with, and successfully purposed and repurposed community health workers for various services. As I mentioned, I've not only worked within the health sector as a community health worker, but also in the educational sector and the social service sectors. Whatever you want to use the community health workforce for is possible, but you have to have plans to repurpose it well. And this would often lead to a very successful and significantly successful reduction of inequalities, sometimes and mostly costs. And it also creates effective and efficient use of the workforce, the health workforce. Just a quick introduction of myself. I'm Stella Lartey. I work with the University of East Anglia as a researcher and as a lecturer. I have colleagues here, colleagues all around, all over the world here. I acknowledge you and thank you for all your inputs in my research work. Basically, my research work has often focused on creating sustainable access to healthcare and reducing inequities, and also building effectiveness and efficiency improvements into interventions, mostly targeted at aging populations and reducing risk factors for non-communicable diseases. Now, I'll stop sharing my slides and then hand it over to Christine. Thank you very much for your time.
Well, and a big thank you to you. I think quite clear from comments in the chat, and you could feel everybody's engagement that was not only fascinating, interesting, but really relevant to lots of people. Stimulated some interesting comments from people working in Westminster, nearby to where we are currently. And our colleague Joanne Hawes has already highlighted some of that work to C3. But if I could take some questions, invite people to switch on their microphone and camera to ask their questions. So Adam Wagner was the first questioner, followed by Barbara Stillwell. So Adam, can we hear you made a question and a comment, and obviously we've only slightly under 10 minutes, so as crisp as possible, and I'm sure Stella will be reasonably crisp in her reply. Adam, over to you.
Thank you very much, Stella, for the presentation. Side note, I work with Stella, so I should make that clear. Stella, in the earlier part of the work, you contrasted the controls with having the care workers and the nurses working together. I just wondered how that differed to the controls. So, for example, were those staff already in the community and you were just repurposing them, or was it a kind of a program of you, the program that you put in place was utilizing them more effectively? So question, how did it differ to the control, so we get a bit more context of what the intervention was doing?
Great, thank you. So first, I'll refer you to the paper and I'll share the paper with you so that you can get a clear understanding of what we did. Basically, we picked individuals from within the community. There were times that we had to actually bring community workers from other close by neighborhoods who can understand the languages, who can understand the culture. And so it's a combination of both, some from outside, but close neighborhoods, and some from within. Thank you.
And I'll just follow up on my next question very briefly.
Very
You talked
quickly.
about explicit operating procedures. Did that create any challenge with allowing the staff flexibility to adapt to the local needs and contexts?
Of course, there were challenges because, for example, I was raised in the eastern region, somewhere close to the eastern side of Ghana. I had to be in the Ashanti region, the center of Ghana, quite close cultures, but still different. And so I faced challenges. I saw community health nurses also struggle, but these challenges were overcome with time as we became accustomed to the communities and their cultures. Thank you very much, Adam.
Thank you. So
Thank
Barbara
you.
Stillwell, followed by Niranjana Prasad. Hi, Barbara.
Hi, everybody. Thanks so much, Stella. That was really interesting. My question is about the thorny issue of payment. I wondered if your community health workers were paid. It was a discussion we used to have a lot during my time in working in international development and public health. Some people thought community health workers should be paid and some not. And I'm thinking, if we're going to apply it here, much as I love the idea of volunteer CHWs, 2 in every street, with the looming recession and the rising costs, I just wonder whether we would get volunteers to do that. Thank you.
Thank you very much, Barbara. So this has been a very thorny issue, as you have pointed out clearly. In some cases, we had to urge volunteerism without payment, but the thing is we had to pay for their transportation. The daily operationalization had to be paid for. But the individuals, some of them volunteered, and sometimes we gave tokens and gifts. You will call it gift card, but we call it gift packages, and in some way of incentivizing them. Sometimes we had to support volunteers and the volunteer families in providing some food that would go into the community. We also included their families. So there were a number of means to incentivize them. And when necessary, we discussed issue of payment. But of course, they were not paid as we would pay a trained health worker, much lower payments in a form of incentives. Thank you very much, Barbara.
Thank you, Stella.
Then can I invite Niranjana to speak,
Yes.
followed by Richard Fordham.
All right, thank you. Thank you for the presentation. I just had one quick question. Were you able to disentangle the mechanisms by which your treatment arm affected the outcome of the community, members of the community? So were you able to say whether if it was increased information that you give to these people, or did you elicit more trust in institutional services? So, I mean, if you were able to disentangle the two, maybe your training could, the mechanisms could, your training modules. Thank you.
Great, thank you, Nira. So I would often say that in any RCT, sometimes we have challenges with disentangling effects, but of course we did as much as possible to disentangle effects. The paper is embedded in the slides. I'll be happy if colleagues can look at how we're able to work disentangling the effect of just the community health worker, the nurse, community health nurse, and the combination. It's a number of strategies that I may not be able to discuss here, but thank you very much. Please refer to the paper for more on this. Thank you.
Great, thank you.
Thank you. Richard Fordham, I'm not sure whether there was a question or just a comment there, followed by Michaela Nuttall.
Sorry, yes, hello.
You're welcome.
Thanks, Stella. I work with Stella too, so just to let you know. I found the talk very interesting. The reflection I have is having worked in Australia for a number of years, and seeing the Aboriginal communities being supplied with healthcare is more of a fly in, fly out, as they call it, their FIFO kind of service. But they're now developing community health workers amongst their own people, and I think that is the key to it. There's certain advantages and disadvantages of both, but I just wondered if you had any reflections on whether you believe that the community health workers should be developed within the community, from within the community.
Great, Richard. Thank you very much. And so Rick is a great colleague I work with here. So coming to whether we should generate the individuals from within the community or outside the community, sometimes it's quite challenging to do this, because based on my experience, there are a lot of times that we picked individuals from within the communities. But there were also challenging moments when we were not really finding volunteers within the community. And so we had to train people from outside the community to be able to help within the community. We needed to learn together the community communication channels and the organizational settings of the community with this volunteer to be able to work within the community. I don't know whether I've totally responded to your points raised, but we can discuss this much further. Thank you.
Thank you. Thanks, Stella.
Thank you. And very last comment from Michaela, if you take yourself off mute, but we've only a couple of minutes.
So I'll make it more of a very short comment, and maybe I'll get in contact with you separately, Stella, for your views on the project that I popped in the chat. So my name's Michaela. I work with with C3 with Christine, and we've just started a new project called Nurses for Healthier Communities, and it kind of feels like it's building on the work that you've been presenting this morning. So we're trying to engage with nurses from communities Brent, Harrow and Ealing to help support those nurses who are going through extra challenges, but also how they can work, how we can help them engage with their local communities. So it was more of a plug. If anybody wants to get involved in that, I've popped it in the chat. But Stella, if it's all right with you, given the time, I'd love to drop you a note separately to be able to pick your brains a little more, if that's okay.
I think there's a danger that Stella might have unleashed a host of questions and comments. So just shows how really good the session was and how interesting. I think we've had commentary from two groups with a lot to offer this debate. The Westminster group, which, as I mentioned, our colleague Joanne Hawes has given us some insight into, but also the global health research, which has been described. She says, searching through the chat. By Patrick Wilson, among others. I'd like to invite both of those organisations perhaps to drop us a note where we can put a blog on our website and also circulate it to the people who are here to spread that knowledge and information. That's one of the best things that can come out of a session like this, I think. I'm also aware that some people have asked very detailed questions. Silas, I'm sorry we didn't get to yours, but we will look at the chat and either invite Stella or work with her to send you some detailed answers to very specific queries that we sadly haven't had time for, but it's a sign of a very good session, I think, and it was such a good session. A description of something that increases life expectancy and saves money has to be really high on all our agendas. I think there was some very important key messages. There are several, and everybody will have heard their own. We've been doing some interesting work around language just with French colleagues, so even more complex in areas such as Ghana, where there are multiple languages. And therefore both the language and the cultural appropriateness, I think, is something that's really, really important. And your phrase, a trusted bridge, I think is a very nice one that we will take away. So Stella, can I thank you so much for, I think, one of our most successful international seminars in terms of the breadth of participants, the breadth of questions, but most of all, the breadth and the interest of your presentation. We will circulate and share the slides, and we'll look very carefully at the chat messages and make sure that we follow up on all of them. And as one of the chat messages mentions, you're all warmly invited to C3's next international seminar, which will be given by Professor Jo Ivy Bufford from New York, which will be entitled Cities as Drivers of Global Health. Because she's in New York, it will be lunchtime, UK time, 1300 hours, early in the morning for people from New York, and late in the day for people to the east of where we are. But finally, good morning, good afternoon, good evening, wherever you are. Thank you so much for joining. Please stay in touch. And most of all, a really big thank you, Stella, for your contribution. Thank you so much.
Thank you, and thank you, everyone.